Hello, and welcome to the first lecture in our course entitled Cardiac Arrest, Hypothermia, and Resuscitation Science. My name is Dr. Benjamin Abella. I am the Clinical Research Director for an entity called the Center for Resuscitation Science in the Department of Emergency Medicine at the University of Pennsylvania. Clinically, I am an emergency physician, but much of my career is devoted to the study of cardiac arrest. And this course, which is really designed as an introductory course for both the educated lay public as well as healthcare providers, is about my passion of studying and trying to improve survival from cardiac arrest. In this first lecture, I will introduce the topic of resuscitation science and some of the key issues surrounding CPR, defibrillation, and outcomes from cardiac arrest. Now, before I begin, as is customary with clinical science lectures, I thought it would be important to tell you a bit about myself with regard to where I've received research funding. We call this a conflict of interest disclosure. I'm employed by the University of Pennsylvania. I've received funding from a number of entities, including the National Institutes of Health, as well as the Medtronic Foundation and one industry source, Philips Healthcare. I've done some industry consulting for a company called Velomedics and another called HeartSign. And I do extensive volunteer work with the American Heart Association. So you should know a little bit about where my money comes from, but I am happy to tell you that I have no equity or any intellectual property in anything related to any of the topics I will share with you today or in subsequent lectures. And therefore, hopefully, I can give you an unbiased presentation of some of the science and some of the innovative approaches to cardiac arrest.
It's George Hettenbach from the Safety Department here at HUP, and I think that sharing the experience that I had here that took place, I had an actual cardiac arrest here when I first came into my office, right here in the hallway, and upon that taking place, the code team was called and they performed resuscitation on me, and all those things went into getting me down to the ED and then going into hypothermia and then moving me further along in the hospital where I needed care. But I think all that, as a personal person that wound up having experienced this, is a situation where I'm really thankful for what went on from the folks that are here to be able to save my life, and I'm actually back to work full time. But the overall situation is thinking about what all happened. Some people ask me, what happened? I don't remember a thing prior to it happening, other than the tapes that I've looked at that security has of me coming back in the front door and then I disappear from the tape. So the next thing I realized is I woke up on the 8th floor in a room. So there's a lot to be said for that in the overall picture. Moving along, after I had the cardiac event and we did do all resuscitation and everything that went about on that whole situation, kind of scary for my whole family, but the big thing is that I'm here. But through their efforts now at the hospital, and a great thing here is now we have AEDs that are here throughout the hospital in some of the remote areas where we don't have access to code carts. And I think this is a major move forward for the health system and for folks that are here. Because we have the clinical side that works most of the time going to a clinical area, but we're in the outpost here in the major hallways. So it does have a great feeling to have this here and to know that it's here for others besides myself if we should have an event for them to work on. So I've given you a quick glimpse of what's going on. It's kind of unusual to be the person who survived. I think the other piece of that is knowing that my wife is a person that had to put up as the spouse and do everything that had to be done. And I think it was a great comfort to know the folks that were downstairs or the top group that knew what to do as far as resuscitation and the hypothermia and what was going on. So I think this plays a major part in what we're doing today and moving ahead. So I hope this gives you some inkling about what it's like to be the patient and be the victim.
Hopefully you enjoyed hearing from a cardiac arrest survivor who was cared for at our hospital. And I like to always start with the survivor to keep us grounded on what's really important, that is the patients. As we start this lecture, let's begin by talking about some definitions. What is cardiac arrest? Well, as you all know, in all of us, our heart is beating with a regular electrical rhythm. That's shown here on what we call a rhythm strip. That is a normal heart rhythm, and you've all seen this in one fashion or another. If you're a member of the lay public, at the very least, you've seen this on television. When the normal heart rhythm is stopped, you can sometimes, in rare cases, rare thankfully for most of us, develop a rhythm of cardiac arrest. Now what happens in this case is the heart takes up a rhythm that cannot produce blood flow. and blood is no longer flowing through the body. In this case, and we'll talk more about this later, this rhythm is ventricular fibrillation. Don't worry about the terminology. As I say, we'll get to it. But this heart rhythm is no longer able to sustain life. In cardiac arrest, blood flow stops, and there's no blood flow to the heart, to the brain, to other organs. And when blood flow stops, someone quickly collapses and becomes unconscious. In technical terms, we call this the lack of functional cardiac output. That is cardiac arrest, when the heart stops beating. Now, by virtue of the heart stopping to beat, the blood pressure quickly falls to zero. There is no blood flow. And with blood flow stopping to all the vital organs, a person collapses. And this is a very abrupt and complete process. It's one of the things that makes cardiac arrest so difficult to deal with and so serious a medical condition, is blood flow stops instantly and completely throughout the body. Without any blood flow to the lungs or brain, a cardiac arrest victim in many ways is indeed dead. Without treatment, they will remain dead, and only through resuscitation actions such as CPR or defibrillation can a patient be restored to health and life. So when a person has cardiac arrest, they will collapse to the ground and they will appear completely lifeless. They will be unconscious, they will not be breathing, they will not be moving. Now, this is with some small exceptions. In the first few minutes of cardiac arrests, first minute perhaps, some patients may appear to be gasping, and other patients may appear to be having a seizure. This is important for healthcare providers to know, as sometimes cardiac arrest is initially misidentified as someone having a breathing problem or having a seizure. Without immediate action, cardiac arrest is uniformly fatal. The immediate actions required include both cardiopulmonary resuscitation, that's CPR, and many of you know CPR or have taken CPR classes. That's the action of pushing on the chest and breathing in the mouth to keep blood and oxygen moving through a person in cardiac arrest. The other key action is electrical defibrillation. And again, those of you who are members of the lay public, you've certainly seen this in movies and television where paddles are used and someone shouts clear and electrical energy is given to a person's chest. That is defibrillation, and we will talk about that more in this and subsequent lectures. Now, it's important to realize that both CPR and defibrillation are actions that can be done by the lay public. You do not need to be a healthcare provider. And indeed, there are many cases where it's essential that members of the public know how to do CPR and understand how to use what's called an automatic external defibrillator. We will get to these concepts also multiple times throughout this lecture series. Now I'm going to show you a manual defibrillator, the kind of defibrillator that we use in the emergency department. The technology in this defibrillator is actually quite similar to that you might find in an automatic external defibrillator, or AED, the devices that you'd find in an airport or train station or other places. The idea is the same, a couple of different bells and whistles. So this here is the defibrillator that we use, and if someone comes into the emergency department and they're in cardiac arrest, we of course have the defibrillator on already. And you've probably all seen this on TV in some fashion. They're defibrillator paddles, and these paddles deliver a very large electric shock to a patient. They go on a patient like this. I'm not going to do this to myself, but that's where they would be placed. And if you need to do a shock, you charge the defibrillator. When this beeps, that means it's ready to deliver a shock. That means this is primed. And you hit the button, and a shock is delivered. Now, in reality, I'd have these paddles on the patient's chest, and much like in the TV show, I'd say clear, we'd hit the button, and the patient would show the evidence of a jolt, and hopefully their heart would restart. So that is the way a defibrillator works. Now I'm going to demonstrate how CPR is actually performed. And we're here in the emergency department where I work, and we have here before us a mannequin, and I'm going to show you what is CPR, both for healthcare providers as well as for the members of the lay public. So if you're watching and you're a member of the public and you're out in the street and you see someone collapse, the way we do CPR is exactly the same. So when you come across someone who's collapsed with cardiac arrest, the first action is to actually make sure they're in cardiac arrest. So we gently shake someone and ask if they're okay. Are you there? Are you there? Are you okay? And if they don't respond, you have to assume that they're in cardiac arrest. And what you do is you take two hands and you put them on the center of their chest. And the goal of CPR is to move blood throughout the body. And so the American Heart Association teaches that you do compressions at 100 per minute and at least 2 inches of depth. So here's what it looks like. And you see I'm compressing continually as hard as I can at about 100 times per minute. The American Heart Association mantra is to push hard and push fast. And that's all there is to it. Now what that was what we call hands-only CPR or compression-only CPR. There's another form of CPR where you also do mouth-to-mouth breathing, and you may have learned that in years gone by or seen it on TV. And the way mouth-to-mouth breathing goes is like this. Pinch the nose, tilt the chin, and breathe for the patient like that. Now, if you're a member of the lay public, we generally advise that you should only do mouth-to-mouth if you feel comfortable doing it or you've been trained in doing it. If you're not trained or you don't feel comfortable for whatever reason, doing compressions just with your hands has been shown to be equally efficacious and is perfectly okay. Hopefully you enjoyed those demonstrations so you can get a first-hand look at defibrillation and CPR. I thought now I would take several minutes and go through what is, I think, a very interesting history of where we got to where we are today with CPR. You may not realize this, but actually in the Bible itself, there's a reference to something very much like what we think of as mouth-to-mouth resuscitation. It happens in the book of Kings, in chapter 2, when Elijah is said to have treated a child who collapsed in a field. And it directly says in Kings that Elijah put his mouth upon the child's mouth and the flesh of the child waxed warm. Now, I can't say whether or not the biblical writers knew anything about mouth-to-mouth or resuscitation science, but it is interesting to note that even at this early stage there was some notion that you could breathe life into someone, that someone who was lifeless, you could put your mouth to their mouth and bring them back to life. At least the concept was there. Now, over time, there were many notions of this concept of breathing for people or applying air to someone's mouth. And as early as the 1500s, there was this concept that if someone drowned or had smoke inhalation, much more common problems back then than actual electrical heart rhythm problems, you could use a bellows and actually breathe into their mouth and restore air to their lungs and maybe revive them. Now, it wasn't clear how successful this practice was, but it was documented and written about through the centuries. And it definitely fell out of practice, and we certainly don't use bellows today, although we do something awfully similar when we use mouth-to-mouth breathing and bag valve mask ventilation, which you also saw in the video that I just showed you. In the modern era, with what we consider to be today's CPR, it was really invented by a few different people. Arguably, doctors Knickerbocker, Kuvenhoven, and Jude at Johns Hopkins in the 1950s, through studying defibrillation in the animal laboratory, discovered that if you push on an animal's chest, you can generate blood flow. In parallel, someone named Peter Safar developed mouth-to-mouth, and these two things together are what we consider modern CPR. Here you see Peter Safar also doing his work in the 1950s. By the way, that's Peter Safar who's actually holding the patient's mouth and breathing for the patient. Peter Safar discovered that you could breathe into someone's mouth and sustain oxygen in the body. And when you put Peter Safar's mouth-to-mouth together with the Johns Hopkins group chest compressions, voila, you have modern CPR, which is, depending how you date things, dated from 1960. Was when it was first described, and very rapidly throughout the world, conferences and symposiums sprang up teaching this new form of resuscitation, this rescue breathing and closed chest cardiac massage. This is an early such conference in Norway in 1961, spread all over the world. And it really led us to where we are today with a variety of forms of CPR training available to both the healthcare providers population as well as to the general public. In 2012, just so you understand where we are today, we use guidelines that are published in the United States by the American Heart Association. These are actually international guidelines produced worldwide by a group called ILCOR, the International Liaison Committee on Resuscitation. And they're the foundation for a variety of courses. Healthcare providers are all familiar with the terms BLS, or Basic Life Support. That's the actions of CPR and using an automatic defibrillator. Many healthcare providers, such as most physicians and many nurses, learn ACLS, Advanced Cardiovascular Life Support, and this involves the use of medications and the identification of different heart rhythms and so forth. So these are the flavors of courses where you learn how to do resuscitation for cardiac arrest victims. And at the end of these courses, you get a card. It looks something like this, depending on the organization issuing the certification card. And you can become a certified provider. Many of you in the lay public who are lifeguards may have done this. And indeed, many people in the public get certified in BLS, usually not ACLS. Now, there are training programs just for using defibrillators. There's also a variety of newer forms of CPR training that we will talk about a little bit more later in this course. There's video-based CPR training. There's something called hands-only CPR, which is without the mouth-to-mouth breathing. And that's a very interesting new topic that we will spend some time on in the next lecture, which focuses on CPR. Now, in the year 2012, there are a number of exciting and new directions, including hands-only CPR. And as I say, we will get to this later, but just to introduce the concept, the American Heart Association and a number of groups have really pushed the notion that if you just do chest compressions, if you just push on someone's chest in cardiac arrest, you may be equally successful as if you did mouth-to-mouth. In other words, mouth-to-mouth breathing may not be required for victims of cardiac arrest. Pushing on the chest alone may be enough. And indeed, this has affected the guidelines. In 2010, when the most recent version of resuscitation guidelines was issued, the time-honored ABC of resuscitation, which stood for airway first, then breathing, then circulation, meaning the order of attention that should be paid to a cardiac arrest victim, this was changed. And this was changed to CAB, meaning now we focus on circulation and moving blood first. That's what is provided by pushing on the chest, then airway, then breathing. Sounds like a semantic change, but this was a big change. ABCs were the fundamental concept of resuscitation for decades, and now we teach students and the public CAB, focus on compressions first when you find a victim of cardiac arrest. And as I said, we will talk much more on this in Lecture 2. This first lecture is intended to give you a broad survey of the topics we shall be covering. And another very important topic that I think, we need to really get across early in this lecture series is an important definitional one. That is the difference between cardiac arrest and heart attack. I think many of you, especially in the lay public, may think there is no difference, or you've heard these terms used together, and I wouldn't blame you. The media does a terrible job of using terminology precisely. Cardiac arrest and heart attack are different things, and I want to go through this in a little bit of detail. A heart attack, the technical terms being myocardial infarction, or sometimes MI, is when you have blockages in your coronary arteries, which are the arteries indeed that feed the heart. So when you get these blockages in the arteries, pieces of heart muscle lose blood supply. So I want to go through this in a little bit of detail here. This is a normal coronary artery. This is a blood vessel that feeds your heart. Some people, by virtue of such risk factors as smoking, high blood pressure, eating a diet high in fat, can develop blockages in their arteries. And you've heard of this before. This is atherosclerosis or coronary plaque. Sometimes these blockages in our arteries can become so severe that they can prevent blood from flowing to a piece of heart muscle. And this is a serious condition that can lead to myocardial infarction or heart attack. So in heart attack, you get a complete blockage of an artery, and a portion of the heart muscle, shown by the arrow in this diagram, a portion of the heart muscle suddenly loses blood supply. But note, the heart does not stop beating. A small piece of heart muscle is in trouble. But in most cases of heart attack, the victim lives and does not need CPR or defibrillation. So what do you do for a heart attack? Well, you can take an aspirin. That's felt to be a very important action that you can take if you have a loved one having a heart attack in front of you. Patients need angioplasty. Sometimes they get something called a stent, and sometimes they get medications to treat this, medicines that are often called blood thinners or anticoagulants. Notice these are not the treatments for cardiac arrest. These are the treatments for heart attack. And this is why it's important to go through this definition. For cardiac arrest, these will not save your life. For heart attack, these are important. So to go through these by comparison, in cardiac arrest, the heart stops. Cardiac function stops suddenly. In a heart attack, a portion of the heart muscle is starved of blood flow. In cardiac arrest, the symptoms are the complete collapse of a patient. A patient becomes comatose. In a heart attack, the patient usually does not become comatose, but they may complain of chest pain or nausea or shortness of breath. In cardiac arrest, there's no cardiac activity. Whereas in a heart attack, indeed, the heart continues to beat in most cases. Cardiac arrest has a very high mortality. By virtue of the heart stopping, many people die. However, in the year 2012, I'm happy to report that most people with heart attacks actually live. And the treatments, as I described, are completely different. So hopefully now we can work together as partners to help spread the word on the difference here. And you can share with me my cringing every time I see in the media them talking about cardiac arrest when they mean heart attack and heart attack when they mean cardiac arrest.